So everyone is clear about the J point and TP segment. You can see from the TP segment, this is our TP segment, this is our reference line, and if we draw this further, then you can see that J point and ST segment is elevated. TP point is a straight line or isoelectric line, which is our reference point to see ST elevation or depression or PR depression. Remember that most people take this line, the PR segment, as an isoelectric line or reference point. But sometimes the PR segment can be depressed, such as in pericarditis. So the accurate reference point is TP point, the isoelectric line between the T wave and the P wave, which is this one. This is our reference isoelectric line in reference to which we estimate if the ST segment is above this line, then it means it's elevated. If the ST segment is below this line, then it means it's depressed. So we can only tell ST elevation and ST depression with reference to TP segment. Is that clear now? Now, now, now. Now look at this ECG. Look at this ECG and tell me what are the changes in this ECG. Look at this ECG carefully. You have to remember that first look at the inferior valves, which are lead 2, 3, and AVF, then anterior valves, then lateral valves. Yes, there is ST elevation, but tell me in which leads? In which leads you are seeing ST elevation? V1, V2, V3, V4, and AVL. In AVL, ST segment is elevated. That's right. V5 also has ST elevation. That's all. Asif, in all chest leads, the ST segment should be in line with the isoelectric line or the TP point. AVL also has ST elevation. So other than AVL, which are the other lateral leads? Look at all the lateral leads. There's lead 1. Is there any elevation in lead 1? Yes, there is elevation in lead 1 and lead AVL. There is elevation in V1, 2, 3, 4, 5, and 6. So anterior and lateral both valves are involved. So it's an anterior-lateral MI. Anterior-lateral valve MI. Now can anyone look at lead 3 and tell me what are the changes in lead 3? Changes in lead 3. Excellent, Dr. Musharat. Negative what? There's a T wave inversion and ST depression in lead 3. T wave inversion and ST depression in lead 3. Now let's tell me with the cursor. Now first of all, let's look at the lateral leads. This is P wave and the segment before P wave is TP segment. So this is our reference line. Let's draw the reference line. It's here. So this is a Q R wave and see that J point is elevated. The termination of QRS complex and the beginning of ST segment is elevated. So there is ST elevation in lead 1. Now look at the other lateral leads. Similarly, there is ST elevation in lead AVL. Now look at lead V1. This is our reference line, TP segment, and see that this ST segment is also elevated. Similarly, this one is also elevated. This one is also elevated. In V4, it's also elevated. See elevation of from this reference line is almost 4 small boxes. This one is also elevated. This one is also elevated. In V5, this is our reference line. ST segment is elevated. Is everyone following me? Dr. Asif? Thank you. So it's an anterior lateral MI. So which artery is involved and which artery is blocked if there is anterior lateral MI? Which artery supplies the anterior and lateral walls of the heart? Lead, left anterior descending, and left circumflex as well, which are the branches of left coronary artery. So we can say that there is a thrombus in the left, main trunk of left coronary artery. There is a thrombus. Now, can you see in lead AVR? In lead AVR, QRS complex is negative, T waves are negative, QRS complex negative, T wave negative. So remember that the positive terminal of lead AVR, the positive terminal of the lead AVR was at the right hand, and the right hand and superiorly. I told you before that the lead AVR is looking at the heart from the right and superior position, but the current is flowing downward and towards the left. So what will happen if the current flows away from a lead? If the current flows away from a lead, the current is flowing downward and toward the left, and lead AVR is on the right hand and on the upper side of the heart. So it's normal to have all the negative waves in lead AVR. I hope you got this point. Yes, because lead AVR on the right hand and current is flowing towards the left. Normally the current in the heart flows towards the left direction. So that's why it's normal to have all the negative waves, all the waves are negative in AVR. Now let's discuss another ECG. I forgot to tell you about the lead 3. Look at the lead 3. The ST segment is depressed in lead 3. So if the ST segment is below the reference line, then we call it as ST depression, and it's above the reference line, which is TP segment, then we call it as SC elevation. Now look at this ECG. And tell me which leads are involved. In which leads there are ST changes. A patient is presented to you with chest pain. This is his ECG. Now systemically, first look at the lateral valves, then at the inferior valves, then at the anterior valves. That's how you are not going to miss any finding. 2,3 AVF. What are the abnormalities in 2,3 AVF? XT elevation, excellent. Are there any other changes in this ECG in any lead? Asaf, you were asking about the normal chest leads on an ECG. On this side of the ECG, all these waves are normal. Can anyone tell me what are the changes in lead AVL? Yes, there is ST depression and T wave inversion in AVL. So T2, 3 AVF are involved. Which heart of the which wall of the heart is involved in this ECG? Inferior wall MI. And which artery is blocked? Now you see a patient is presented to you with chest pain that gets worse on inspiration, and his ECG shows widespread ST elevation and PR depression. What is your diagnosis? Widespread ST elevation and PR depression. A patient that is presented to you with chest pain that gets worse on inspiration. Pericarditis. Now, in pericarditis, in pericarditis, there are saddle-shaped ST elevation with upward concavity. Can you see the upward concavity in this ST elevation? Saddle-shaped ST elevation with upward concavity. And look at the PR segment. Look at the PR segment. It is also depressed. This is our reference line, and PR segment is below this reference line. So there is PR depression, and ST segment is above this reference line, so it's ST elevation. Now this is an ECG of pericarditis. You can see the ST elevation, the saddle shape ST elevation here. Just see, here is our reference line. PR segment is depressed in this one, and this one, and in this one as well. And ST segments are elevated with upward concavity. V5 wave is also concave, and V4 is somewhat concave, not that much. And there are PR depression as well. Dr. Sir, remember that in a normal ECG, there are no Q waves. Q waves are not present in a normal ECG. If there are Q waves in an ECG, it means the person has chronic ischemia. I hope you are asking about the Q wave and not the Q segment, because there is no such thing as Q segment. Q wave. So in normal ECG, in a normal person ECG, there are no Q waves. Q wave is not normally present in a normal person ECG. There are only R and S wave. If a person's ECG is showing Q wave, then it means he has chronic ischemia. He has ischemic heart disease. Normally, only R and S waves are present on in a normal ECG. This is R wave, and this, look at this segment, PR segment. It is depressed according to the reference line. Which spike are you talking about? The spike is R wave. The spike is Q wave. Remember that Q wave is a negative wave. So the upward spike cannot be a Q wave. Q wave is a negative wave. The first negative wave on ECG is Q wave, and the first positive wave is R wave. The second negative wave is S wave. So Q and S are negative waves, and R wave is positive wave. Just let's see at this diagram in V1. Can you see this small positive wave? Can you see it? And in this diagram as well, the upward wave is R wave, and the downward wave is S wave. Similarly, look at this. The R wave and S wave has almost become of the normal size. They have become equal. Here the R wave is small. Here its size increases a little bit. Here it increased and become equal to S wave. In V4, the R wave is larger and V5 more larger. So this is known as normal progression of the R wave. That in V1, R wave is small. Its size increase in V2, and further in V3 it becomes equal to S wave, and in V4, 5 and 6 it becomes larger than S wave. So this is normal progression of R wave. Q wave is not usually present in a normal ECG. Q wave, so if the Q wave are present, then there is cardiac pathology or ischemia.